Welcome, everyone. I am Edward Ziga, one of the co-chairs of the webinar subcommittee with our manager, Sheridan Myers. We are all welcome. Today is a set of many webinars that have been planned, and we have our speaker today, Dr. Teneasha Washington, will be talking about building a community engagement model for rare diseases, community ambassador approach. And I will speak more about her as we go through a few housekeeping slides. We have dubbed this series as a platform to share ideas and also learn about best practices that we can all use in our workplaces, as caregivers, as researchers, and clearly looking at issues regarding diversity, equity, inclusion, and accessibility that we know persist perennially in things and what we do. We're hoping that this platform will keep us engaged and provide an avenue for us to share ideas that will bridge this gap and improve outcome of our patients in long term. We plan to bring to you presenters who are well-versed in this space, in their field, in multiple aspects of what they do that impact our goal in this field. And you hear more about Dr. Washington today, and you agree with me that she comes to us, someone who is going to give us some tools to work with. Our webinars will be recorded and will all be recorded as we move along on YouTube. I think that the link will be shared with many of you over time so that you can go back and review it in your own time, which I find very, very useful. A real teaching tool for me as a clinician. Okay. So you'll be surprised that I sometimes forget to mute my phone, which I do. I've forgotten now, so I'm going to do right now. I mute my phone. Let's all mute our phones as we to maximize attention as we go through this presentation. We'll try to limit Q&As to the end of the talk so that we can be able to finish the talk on time. And the chat icon is, raise function is available. You can use that. And Denise and I will be reviewing that to get your questions down and answered by Dr. Washington. Very important, we have a post-webinar survey, which has been very helpful to us. We use that to understand the needs of the group and also comments that will help us improve on our, ongoing series. So please, I can't say more than enough. If you can spend 1 or 2 more minutes after the webinar and just click those buttons and give us your feedback. We really, really will appreciate that. And like I said, this recording will be available on YouTube. So before I hand off the platform to Dr. Washington, Dr. Teneasha Washington comes to us from the University of Alabama. She has a doctor of philosophy in behavioral sciences and is from UAB and has stayed on to be faculty. She's actually the program director of the MPH program and has a lot of experience researching in the behavior sciences as part of the public health, the School of Public Health faculty. Dr. Washington's research is focused on developing ways to be able to engage diverse communities, especially those that are marginalized and mostly in the rare disease space. That has led to her forming a consultancy that she leads as the director, sharing ideas with her clients how to improve the deficits of diversity, equity, inclusion, accessibility in their work spaces. She's very, very interested in sharing her ideas, and she actually has also been able to develop some programs, and today we'll be sharing some with us that has been completed, some that are ongoing, but what I'm looking forward to, which she's going to show us today, is some recommendations based on the feedback that was received from patients, caregivers, and other clients or stakeholders in this field that have allowed her to develop some, as to how we can effectively work with this community. With that, I will hand over the platform to Dr. Washington. We're happy to have you today, and welcome.
Thank you so much, Dr. Ziga, and really excited to be able to be here. Also, thank you, Sheridan and Denise, for all the work that went into actually making this happen. But I'm so thrilled to be here, to be able to speak with you all. And I, as Dr. Ziga mentioned, I teach students, so I'm happy to address questions throughout the presentation rather than the end. I try my best to be engaging, so feel free to stop me at any point with anything that you.
We will take you on that then, and we will, Dennis and I will share questions with you. Thank you. Yeah.
Yes, you're welcome. So I'm here today really to talk about building a community engagement model for rare disease. And some of my early work started in the field of disability. So I still actively work in the disability space, specifically with individuals who have mobility disabilities. But I'll talk more about something that we started in that area and how I kind of have used that template as something that I think could work in the rare disease space. So, I mean, all of this background, I think many of us are very familiar with this idea that, yes, rare disease is something that is rare, but when you think about it as a collective, there are about 25 to 30 million Americans who identify with having a rare disease. And of course, we do know that a lot of this incidence and prevalence is within ethnic and racial minority groups. And then in particular, thinking about access to care and how that can be challenging really for anyone in the rare disease space, but think about how that's exacerbated when you're thinking about minority communities specifically. So again, we do know that these disparities exist, and they can exist around a variety of diversity metrics. So when we think about cultural ideas, linguistic differences, language, how people communicate with each other, access to care, of course, socioeconomic and environmental factors. But I always use this as my engaging moment for people, oftentimes outside of the rare disease space. But when we really think about it, we do know that the population, the demographics of the United States specifically, is shifting drastically. And, when we think about the rare disease space, if we continue to go at the rate that we have been going, a lot of our data that we're receiving over the past really decades is going to be limited. It's not going to be very generalizable when we think about the shift in demographics. So I think this is something that is very important that we try to address. So I always tell people, don't worry about my magnifying glass. I'm terrible at slides. I'm not a graphic designer. Don't consider myself to be any of those things. So I always use the design feature in PowerPoint. Okay, that's me. And I picked the first one that comes up. But why do we see this happening? So why do we think that people aren't engaging with us? And I say that as a Black woman that works in a university, that also goes out in communities, and people are like, oh, Teneasha, you can do it. You can talk to them. And it's like, nah, that's not how that works. Just because I'm a Black woman, I have multiple degrees. When I go to a community and I say immediately, I work for the University of Alabama at Birmingham, there's a drastic difference in how they communicate with me versus someone within their community. So we know that this happens in a lot of different ways because of mistrust, education, lack of comfort with clinical trials specifically. When we think about, ourselves and how we've been trained in a lot of these processes, you have to think about it from a community perspective. If you say, I'm going to blind someone, we're going to blind some participants over here, these participants won't be blinded, people have no idea of what we're talking about. So it's very important that we recognize that and we think about how we can do better relaying information and terms. And then lack of innovative outreach strategies. You know, our jobs limit us on our time with what we can do and how we can engage people. And we're really not incentivized to engage people and build relationships. We're not. We incentivize with publications, finding new grants, you know, all of those service activities, things of that nature. So it's very important that we recognize these, but we also try to adjust them in some way. So why is this important? So why is this lack of diversity important? People always talk about access to care, but just because you have access to care, we also know that that doesn't mean you have quality care. And it also doesn't mean that you have a good quality of life. And thinking about drug outcomes, we've seen in several therapeutics that, you know, they were engaged in the clinical process with a specific type of group. And, you know, it may have worked for that group, but once you come out and you try to make that drug generalizable to a larger population, sometimes there are detrimental side effects to that. Unmet clinical needs, just in general, and then limits our understanding of the differences among the different minority groups that we try to serve. So I know we're all tired of hearing about the bad. We always talk about, you know, diversity. We need more diversity, but a lot of times people always come to me and say, look, Teneasha, I have no idea what I'm doing. I'm not trying to not be collaborative. I'm not trying to not engage other minority groups. I just don't really know how. And so I always try to structure my presentations around the how rather than why these things are happening. So this is a project that was conducted with RareX. I'm not sure if you all are aware of that organization, but they have now since combined with Global Genes. So Nicole Boyce is the lead of both of these organizations, and they recently combined. But I was brought in for this particular project to really create this landscape of what rare disease and DEI look like. And this was at the height of COVID. So there was a lot, you know, pushing around this idea around diversity, equity, and inclusion. And so what we decided to do was to try to do this in a unique way, in the sense of making sure that we tried to broaden our effort as much as possible. We created an advisory board. The advisory board was also very representative. One of the things that I was challenged on early on was this idea of what does diversity mean? When we think about the United States, oftentimes diversity can be Black versus white. But in today's world, diversity is not just Black versus white. So it's very important when we thought about our advisory board, how do we engage and take into account that changing definition of diversity? So we identified individuals as caregivers. We had one woman sit on the advisory board that represents an organization that is deaf and blind. Their participants are deaf and blind. So she was on the board as well. And again, we had parents, all of those individuals as a part of that. It was 7 individuals. We conducted an online survey. It was called Diversity, Equity, and Inclusion in Rare Disease. And this was kind of shifted out into the entire population of what we think of as rare disease. We also conducted some focus groups and some individual interviews with individuals. And the purpose was to really think through people's thoughts and perceptions on what DEI looked like in this space. And this is a report that came out, and we also have a hard copy of that as well. So if you all are interested, I can make sure I send that out for further review after the conversation. But I wanted to show you kind of a little broad overview of who actually participated in this. And people always laugh because they're like, Teneasha, this is about diversity, equity, and inclusion. And we had 63% of the sample was white individuals. And I was like, well, I mean, it makes sense to me when you think about it, if you already work in a space that is really overrepresented in this specific group, that's who you're going to have respond. And I always acknowledge that, because I think if most organizations are led by individuals that identify as being Caucasian or white, it is very important to understand their perspective so that we can also try to engage them in changing this. But I was very excited about the 17% of African Americans, also Hispanic. We had Asian individuals. We also had mixed race individuals as well. And then American Indian, and of course, Alaska Native. And how we tried to kind of engage a lot of stakeholders in this. So it wasn't just, individuals that identified with the rare disease, but we wanted to bring in the clinical aspect of that. We wanted to bring in the research aspect of that. We also wanted to talk to patient advocacy group representatives, as well as caregivers. So you can see who responded to this. And as a reminder, I always keep the N, you see the N equals 100. Those are the number of individuals that participated. And we want to make sure that we say that, just because, of course, this is not going to be generalizable to the entire rare disease space. And this is very important to me because, again, we talk about this a lot, but one of the questions we asked is, what do you think the reasons might be behind the lack of diversity? And 90% of those individuals really identify this limited knowledge of rare disease. And it's something that I have noticed myself within the space, this idea that we talk about how we want to engage, but there's a large group of individuals who cannot identify or are not well-versed in what a rare disease actually is. You can say rare disease all day and they have no idea of what you're talking about. So that really stuck out to me. And then this lack of educational resources, as well as lack of access to medical care. And interestingly enough, the lack of trust, which we all know is there, was relatively a smaller group of individuals responded to that. And I think that's very important because I do want to speak to, it is important to identify that there is this idea of a lack of trust. But it can't be what we say, that's the reason, so we can't acknowledge it and we can't move forward. Because again, it seems to be that the limited knowledge of rare diseases seem to stand out the most. Before I go into how we kind of did this process, any questions so far?
No questions, but this was such a fascinating chart, Teneasha.
Oh, thank you. I appreciate that. Hopefully the rest will be fascinating as well. Okay, so I'll go ahead and keep going again. If you have questions, feel free to stop me. So we also conducted focus groups and individual interviews. And the reason we did this is because I am a big, I advocate for this idea of mixed methods work. So yes, we want to do the quantitative. Yes, we want to add some numbers, but it's very important. If I go back, so we're saying 90% of individuals say, there's an issue with this knowledge of rare disease, but that's all I have. But it's more important for me to find out the why, which is where we bring in that qualitative aspect. So that's why we decided to conduct these. We conducted one focus group with rare disease patients and caregivers. We also conducted individual interviews with caregivers, patients, researchers, and clinicians. And some of the things that came out of that were around education, community support, this idea of equity and inclusion, and then research in general, as well as some others. And I'm going to share with you some of the quotes that came out of that. So this was one. Well, I think that's going to always be, because in the Black community, there's always that just kind of hovering over you, that shadow of distrust when you're dealing with medical information given to you. I just don't take it and go with whatever they say. I am going to research it for myself. I mean, that's just with anything. The lack of trust is there, and it'll always be there until we are made well aware of what's really going on. So this is an individual that was talking about this idea of trust and the lack of trust. I think the other thing that you have to consider is that not everyone has a strong support system. In our case, we have different family members, so that it's a group of us and we take turns. So the burden isn't on one person. We take turns, and because of my work schedule, I'm limited to only one day a week when I can assist. But having a strong support system, even when you don't have the doctors and the medical professionals reaching out to you like a caseworker of some sort, to make sure that you're aware of all of the things that are available to you when you have a strong support system that can fill in that gap. This individual was talking about this idea of this strong support system, which I will bring about more when I talk about this community health ambassador approach. It's just from past experiences, even from other people in my community, the Black community, where we feel the doctors don't really listen to us, or we are misinformed, uninformed, and pretty much ignored. That has been going on for years. It is pretty much embedded hearing these stories from friends and family that look like me and have the same race, you always second guess what's being told. And I'll just throw the other ones up here. I won't read all of them. This was one about distrust, specifically about the Tuskegee experiment that happened. And then this is just more about people just participating in some of the work that's going on in the space, in the field. Okay, so how do we take that information? And there's more in the report. There are plenty of quotes in the full report, but what does this mean? So, we sat down and we thought about this. What are some actual strategies to address this? And one of the things, and I'm sure you all have heard it, and we say this all the time in the disability space, is meeting patients where they are and meeting people where they are, and really thinking about our work as being people-centric rather than this idea of research-centric. Offering informational sessions for people that are saying they are not aware of what a rare disease is. How do you engage them? Having a diverse staff. So anytime that you're going to go out and say, hey, I'm working in diversity, equity, and inclusion, and then you say, we want to ask you some questions, and your entire staff looks like you, it's very hard to really say from their perspective, they may not know about your staff, they may not know about you. So if they see that and you're coming in talking about, we want to create this diverse team, it's a little different when your team is not diverse, okay? So really thinking strategically about what that looks like. And of course, including family members within this process. Including patients, providing transportation, flexibility in hours. Everybody can't meet between the times of 8 and 5, particularly people who have multiple jobs, and disseminating newsletters, keeping people engaged. But most importantly, and this is what I found out in my own work, is this idea of relationship building. I always give this example, when we think about it, let's say you're walking on the street today and you're trying to get from one meeting to the next. If a random person walks up to you on the street and says, hey, give me your number, are you going to give it to them? This is not a natural process. So why do we think that we can walk up to people in communities and say, hey, I'm here to do a research study, give me your information, without building any sense of relationship or engaging them in any type of way outside of that research? So I'm going to share with you, I remember I talked about working in the disability space and building out this idea of community health ambassador. And this is how we started. So I was working on a CDC grant, and the CDC allowed us to give out micro grants out of this larger grant fund. So what we decided to do was to give out 4 grants within the Birmingham, Alabama area, within neighborhoods. So we have 99 neighborhoods here in Birmingham, and each of those neighborhoods are represented by what we call a neighborhood president. And these individuals are elected individuals over their neighborhoods. So we took them through an actual grant process. We developed a FOA. We put that out there. We had an informational session where they could ask questions. We talked about, what the requirements were as a result of that project, and then they submitted their application. I had my PhD students grade and score their applications. They gave them feedback, their thoughts, and then we awarded, as I mentioned, 4 neighborhoods. And each of the neighborhoods received $20,000 to implement some type of health promotion program that could include individuals with disabilities. And this neighborhood is West Goldwire. It's a predominantly kind of an older representation in the neighborhood. Older individuals live there. And these are just some graphics of what that looks like in the Birmingham space. And then you see you're like, okay, Teneasha, but who are these people at the top right on these bikes? And so this particular community partnered with an organization called Team No Breaks. So Team No Breaks was started during COVID. And it was this understanding that a lot of people, had reduced access to care, and people were trying to get active, but they didn't know how to get active. So this group was like, hey, we're going to start a group where people can get on bikes. I was a part of that group of people that got on a bike. And just to let you know, you see these nice bikes in this picture, but many of us started out on Huffy bikes, okay? I came out in a purple Huffy bike. And if you cycle, you know that that is really not the best bike. But I give that to you as an example of this bike group did not start with the intentions of everyone, owning, a nice bike to engage people. But these individuals were a part of this program. And what they did was they worked with people in the neighborhood and the neighborhood president with increasing access to physical activity. So people who were elderly or had some type of injury that prevented them to actually get on a bike and sit on a bike, we bought them these little bike pedals that they could they move their legs and they were still able to get outside. As you can see in these pictures, you see them sitting outside pedaling. You also see the other group of individuals on their bikes, getting out in the neighborhood and riding. And this was so impactful just because it showed that, look, through the neighborhood president, not necessarily me, guiding every effort, that people could be engaged. And not only could they be engaged, they wanted to be engaged. People were they were excited to be able to get on a bike. They were excited to just be outside and pedal. And, it was fun for them. In addition to that, the other neighborhoods, one neighborhood focused on gardening, making accessible gardening. Someone was in a wheelchair, they couldn't get to the garden that was in the neighborhood, so they built raised beds and other things for that individual. One neighborhood gave internet access to their entire neighborhood. This was right at the cusp of COVID. So the whole purpose of this was to be in person, but we ended up having to do a lot of things virtually because COVID hit us. But that was very important with the other neighborhood because that's why they wanted to give internet access. And through that, they were able to offer programs that were accessible through the internet because a lot of the individuals in the neighborhood didn't have internet access. And last but not least, I think I missed one. We had the internet, we had gardening, we had this, and then, okay, yeah. So that was most of how all of these worked. Any questions so far? And then I'll kind of show you how we're trying to embed this within the rare disease space. Any questions? Okay, so I'll keep going. And this is just the last picture of this group, all of them together and just having fun. So how did we decide to take this kind of idea and bring it to the rare disease space? So I am very big on this community health ambassador approach, as well as, you can think of it as a community health worker, if you like. So this is all in rare. This is another program that, again, is with RareX. There is the CHC Community Health Council of Wyandotte County, who's a part of this, as well as Rare KC. And we call this Patients Data Powering Progress, Harnessing DEI and Rare Disease Data. RareX has a platform that they're building around data collection in rare disease specifically, and in the larger community as well. So what is the purpose of the program? And I have this outline here, but I'm not going to read each of these. The idea is really at the forefront to engage people around health. And I call it sprinkling rare disease as a part of that, because we want to go back to this idea that, remember, 90% of individuals said that people don't know what a rare disease is. So how do we engage them in their health in general, but at the same time, speak with them about what an actual rare disease is? So this project is really threefold. We're engaging by developing this community health ambassador approach. We have a pastor here is with congregations. We have a congregation here in Birmingham. We also have a congregation in Kansas City that we're engaged with. Each of these congregations will identify one individual within their church that will serve as the community health ambassador. Those individuals will go through a training, a specific training, and we'll talk about that. I'll talk about that a little later, that will prepare them to be able to engage individuals, not just in rare disease, but just in their health and how do they live a quality of life based off of what their, whatever their situations are. And just to go back a little bit, now the community health of Wyandotte County, one of the partners, they already have an active program in Kansas City where they have trained over 20 community health workers. And these community health workers speak over 20 languages, and they are already actively in communities. But our idea is this idea of starting with patients and caregivers, of course, and building that out, building that where we engage trusted community leaders. So for us, we started out with these congregation. Again, this is a pilot. It doesn't mean that that's going to work in every community, but these congregations have people that, you know, are well known. They're like, hey, if I have a question about this, I'm going to go to that person, even if they're not going to have the answer, just because I trust that individual. And then support these individuals by training them and teaching them also on IRB protocols, research protocols. So for sustainability purposes, we're not just sucking information out of people, but we're also giving them skills that they can use in other projects as well, outside of this one. So again, bi-directional education, I always say that because yes, I have all these letters behind my name, but it doesn't make me an expert. People in communities are their own experts, and oftentimes they have taught me a lot more than I consider myself teaching them. So what does this look like in our pilot? So I mentioned that we have one Kansas City congregation. We also have a congregation in Alabama, but the center of this is trust, building this idea of trust. So not coming into communities and asking them specifically, give me your data, give me information, but building a relationship with them. And then throughout that process, should they want to engage in giving additional information, they can. So again, they have this patient portal that they're building. So people will have the opportunity if they say, hey, you know what, now that you kind of educated me and talked to me about rare disease, I do know some individuals in my family that have a rare disease, or I have a child that has been having, you know, a lot of different things going on with them, and I don't know what it is. Maybe it could be a rare disease, and linking them to the care that they need. Providing them support, and then of course, identifying individuals throughout. So I talked about this a little earlier. This is the Community Health Council of Wyandotte County. They have over 20 community health workers, combined 90 years of experience in a variety of different health specialties. They are also fluent in more than 11 languages. So there are a lot of individuals that may not speak English, or it may not be their first language. They try to bolster that in that area. And don't think that this is just a regular training. Like, they are trained, and I'll talk a little bit about the curriculum as well. And as you can see, they have over 435 hours of training around community health. And they are seen as a trusted community partner within their area. So what does this training look like? And of course, we're probably not going to use all of these for this program, but just wanted to show you where this 400 to 700 hours of training comes in. So you have your community health worker training, and then you also have like a Healthy Heart ambassador. What does that look like? Leadership training, because we want them to be empowered to be leaders as well as they go out and engage people within these congregations. Medicaid and Lifeline enrollment, speaking to support services. So working with individuals, identifying, you know what, this person may qualify for Medicaid. Maybe they've never had access to healthcare. Maybe this is the way to engage them. And then they also have like safe sleep and things of that nature. And this is the additional training that we would like to include. And as a part of this program, something that we're trying to build, or even engage others who are actively doing this work. So providing, of course, an introduction of the project, providing some type of rare disease education. So we're actively building on that. In addition, identifying other curriculum that may exist outside of this program, advocacy and outreach, introduction to the research process. What does that look like? So we will train them on like city trainings and things of that nature for IRB, again, so that they can have skills that they can use outside of this project, should they want to, and then other little different areas. So training support includes us, of course, participating in that process, and then also meeting with the pastors and the network. So we have a community advisory board that we plan to engage around this project as well, that will serve as these high-level individuals that anything that we decide, they would have to co-sign and say, hey, I think this makes sense. Hey, Teneasha, y'all need to take a step back. This is not going to be representative of who we're working with. These individuals also are paid. Just like we as researchers and clinicians and all of these things are paid, they are paid as well. And they're seen as true partners throughout this process. These are just our overarching goals over the year. So starting this year up until December, our main goal literally is to train these workers, these community health ambassadors. I'm going to call them health ambassadors, to train them, make sure they're trained efficiently. In the process of that, also thinking about creating that curriculum that I mentioned earlier, that we hope to engage individuals on. But those are really our two large ideas. Once they are trained, the community health ambassadors will go out and offer events within their congregation. So for example, what they're going to do is, hey, they're trained, maybe every first Saturday of the month, we're just going to have activities. Maybe we have a community health fair where we don't just invite their congregation, but we invite the larger community to talk about their health, to talk about diabetes, to talk about high blood pressure, to talk about cholesterol levels. And then in addition to that, have information that's related to rare diseases as well. So we can start building their knowledge base around that. Offer resources for them, should they need them. Individuals that would like to be kind of sent to other areas for additional resources, should they identify with having a rare disease. There's a network here in Birmingham. We have a lot of activities around rare disease that we can send them to clinicians that work in that space so they can have and receive the resources that they need. In addition to that, offering things and activities, sending out birthday cards, getting people's information if they wanted to share so that we can engage them throughout this time. Maybe a birthday's coming up, creating newsletters, but not coming in with this idea of within a month, we're gonna ask you for your data and you need to put it in our system. But coming out with the sincere, hey, we are here, not just to help, because you don't just need our help. You have a lot of resources in your own community, hence the community health ambassador and how they will serve as the communicator. Yes, we are here as a support, but we will not be leading the project. These community health ambassadors will identify events. They will engage the congregation members. They will participate in identifying resources throughout this process. And I know it's 1:40 and I should be done. Yeah, I like to offer more questions and answer questions more than anything else and provide additional resources or anything else that you all may need rather than talk to you for the entire time. Any questions that you have for me?
Dr. Washington, thank you so much for a very engaging hands-on presentation. Clearly, I took a couple of nuggets from this presentation. It was intriguing how you model this. This question here. Okay, a comment here. Incredible presentation. Thank you. How it was modeled through the faith community. Was that something that was designed, or it just evolved as you went along with developing this year?
Yeah, that's a great point, Dr. Ziga. So really, we wanted to start off within these faith-based entities just because it seemed to, I know in the South where I am, congregations are really people's kind of outreach of their family. It is something that is ingrained in their communities and what they like to do. So it was a natural starting point for us. However, one of the things that we have come to realize, and one of the things that I've mentioned is, yes, congregations can be a great resource. However, we do know that that's shifting. Our younger generation is not necessarily as engaged within the congregation space as older generations are. So what does that look like? But we really just wanted to start somewhere based off of what people were saying to us. And that seemed to be a good space, but we also wanted to include the rural aspect, which is why we added Kansas City as well, which is a very rural area. But our goals outside of congregations will include other areas. So, but we want it to be specific to population. So for example, for the Hispanic community, what would that look like? We don't think that this is the best approach for potentially a Hispanic community, but we want them to be able to tell us what that looks like for them. And we can use the same type of model to engage that community, but it would be different from the congregation that we've listed here.
Thank you. Now, sorry if I'm taking anybody's, there's no other question. So I will ask again. You talked about people who identify the community as leaders. Is that unique to Alabama, or we have that structure in other communities across the US?
I mean, I think it's just the structure of people and how we think. You know, there are people, if you think about even at your job, there are people at your job that, you know, if you want to get outside the politics of your job, you go to ask questions, or you're like, hey, I really can confide in this person. And we decide that those individuals are the ones that really are influential in their communities. And I feel like everybody has that. They have a couple of those. But rather than bringing in, you know, this huge research team, those individuals on my research team may not be a trusted individual within this different space. So why would I want them to be the face of the program? You know what I mean? Dr. Zegan, I'm sure you know, but maybe it will work, maybe it won't. But that's the idea. Instead of us thinking that we have to run everything and everybody has to go through us, identifying people that are trusted within these spaces that can serve in this role as well.
Yeah, I thought that was effective. So are you proposing that knowing the dynamics of your community should be one of the first steps you take before you even begin to, okay.
Definitely. And I think that goes with conversation. That is the first part of actually engaging, Dr. Ziga, this idea that yes, this may be a phenomenal idea, but it may not be the best approach for different people, and identifying what the best approach would be for them. But still, you can, I would argue that you could still use this community health worker or health ambassador role within those individuals in their cultures, but it may not be at a congregation.
Any other questions from the group? Well, questions. You had mentioned some materials you could share with us over time.
Yes.
If you send that to Sheridan, we'll be happy to have that. And I'm going to go back and look at your slides in more detail. There's a lot of stuff on these slides that I couldn't even run through. Anyone else a question? Let me see.
I know Ruth has one, Dr. Ziga. I see her hand.
A question from Ruth Ann, is that right?
Yes, thank you. It is Ruth, and thank you so much. One of my questions that I have is concerning what's your idea on how we engage the whole community? So in asset-based community development, one of the things that you talk about is looking at the assets in the community. So where the stores, you talk to the store owners, the business owners, every social work agency that's in a certain parameter or certain area, you talk to the schools. So you end up connecting with different types of leaders versus just like the overall leader. So what's your thought on that? And did you use that approach in your work?
Yes, I love that. And I completely agree. One of the things that I've learned is that, we're trained to think that we are the asset, right? We're the asset, and that's what we should do. We should go. But one thing that I've learned is each community has their own sets of assets. A lot of individuals may have retired from being a nurse or being something else that is still within communities, but they are just retired, and you can pull in those strengths as well. So even thinking about the community health ambassador in the congregation, oftentimes those individuals may have a vast background in some of those areas as well. But to your point about this resource, so when we think about, I mentioned resource allocation and thinking about individuals that may say, hey, I came out to the community fair. I don't have access to care. What does that look like? So the community health ambassador will have really this landscape of resources within the community that is nearby. If it is pointed out like, hey, maybe I don't live in that area. Are there other areas around that I can receive care within my own neighborhood? So a part of that role of the community health ambassador would be to identify what those are, to go out and talk to the individuals at stores, to go out and talk to people that have community gardens that may be an asset in a community that no one's aware of because nobody's asking those type of questions. So our goal is to build out this round, robust list of resources for people that are a part of the program. And that information could also be relayed to people that are not a part of the program because it's still active resources within these neighborhoods.
I love that, because basically what you just explained is like community asset mapping and keeping that full list of this rich resource list, which most healthcare agencies and social services agencies do not do. And so they always come in, I think we, because I'm part of it, we come in trying to prescribe versus like, we know you have these assets. This is how your assets and our assets can be merged together to help move the community forward the way they think their community should be moved forward.
Agreed. And I mean, some people never plan to go to, you know, your store that's in the central part of the city. I know I worked in one community here locally that their local gas station was where they shop for produce. So thinking about that gas station, if that's where they're going to go, if they don't have a vast transportation system, how can you make that the best gas station for them to be able to get the resources that they need? So I think that speaks to your point and the point that you're making around asset building. An additional factor around that is network analysis. I think that is such a resource that we don't use. This idea that when you are actively engaging in the community, to your point, you build out this vast network of individuals that don't even recognize that they have connections to each other just because they haven't worked together in the same space. So we also plan to build that out into potentially thinking about a social network analysis and how people are connected in the community to the larger area within Birmingham, also in the larger area within Kansas City.
Thank you so much. I think it's about time. I'm sure we'll love to have you come back, Dr. Washington.
Would love to.
Yes, and we'll keep in touch. If there's no other questions, we have about 10 minutes more to go. Otherwise, I will yield that back to all of you to continue your day and get yourself back to what you love to do. I thank you all, and please remember to complete the survey. It's very, very important to us because we want to use that to improve on the work that we have begun. Does Sharon have any question, any other input, or Denise, any other input?
Nothing else for me. Thanks so much.
Okay, thank you all again, and hope to see you in the next webinar. Please look out for emails, invitations to the next webinar. I'm sure it will also always be as engaging as we've enjoyed today. Thank you all, and bye.
Bye, everyone.